my views on modern sulfonylureas in the evolving management of type 2 diabetes with special reference to the Indian landscape. As you know, a lot of new drugs have come in last 10 to 15 years, new guidelines have evolved, and new guidelines talk more about new drugs, but we should not forget good old drugs which have a place to in the management of type 2 diabetes, particularly in Indian realities, and we will talk more about India specific realities. I will quickly go through epidemiology. 101 million diabetic patients, 136 million pre-diabetic patients. Peculiarity is in developed state like this part of India, Maharashtra, Gujarat, South, we have more prevalence of diabetes, but in developing states, we have more prevalence of pre-diabetes, and we know that the chances of conversion of pre-diabetes into diabetes in India is 3 times the Western population. So you can imagine what is going to happen in future. Many more number of diabetics. The peculiarities of Indian diabetics are it strikes 10 to 15 years early, and insulin deficiency is very severe right from the beginning, associated with significant insulin resistance because of the central obesity, and this double-barrel pathophysiological defects leads to multiple complications at a very early stage, particularly since diabetes is not controlled. I think the technicians should take over. Now they are visible. Okay. So this is the problem of our country, and that is the reason why, according to Joshi's experiment, more than 67% of Indian type 2 diabetic patients are not at goals. According to some other trials, including ICMR trial, 85% of the people are not at the goals. If you want to avoid complications in early part of diabetes, glycemic control is very, very essential. Don't try to confuse ACCORD trial with early part of diabetes. In ACCORD trial, they said that glycemic control in a later part of life with old diabetic is not very important. There you should concentrate at blood pressure, etc. And some people are confused. Glycemic control is very much important in early part to prevent the bad metabolic memory. What is needed in our country is need for early diagnosis and prompt initiation of treatment. There are a lot of seminars on prompt initiation of treatment, but nobody talks about the need for early diagnosis of diabetes. What is happening in our country is diabetic remain undiagnosed for a long time with hyperglycemia. By the time they are diagnosed, the complications have already set in and a bad metabolic memory is established. And this bad metabolic memory leads to interaction between the oxidative stress, the glycated products, end products, and they damage the vasculature, leading to complications, and later on that is creating a big problem. The impact of early glycemic control on future complications of diabetes, there are certain excellent studies such as this diabetes and aging study. What essentially they have shown is as follows. They have taken those diabetics who were started treatment early on, and they have viewed their glycemic control at 6 months. Those at 6 months having HbA1c of 6.5 or below were compared to those having higher HbA1c, 6.5 to 7, 7 to 8, and so on and so forth. And these people were analyzed for micro and macrovascular complications after 5 years. And what they found out that if you are not reached a tight glycemic goal early in the management of diabetes, then you are exposed to higher microvascular as well as macrovascular complications. So this is the study which stresses the importance of early diagnosis followed by prompt aggressive treatment is the need of the day. UK PDS 24 years after the initial close-up of the trial is still showing beneficial effects of those who were on incentive treatment for first 5 years. Micro and macrovascular complications were less. So what needs to be done? We need to aggressively overcome inertia for diagnosis of diabetes and for aggressive treatment. Once the diagnosis is done, we have to strike hard and strike early with the best possible agents which could establish control very rapidly and very swiftly with minimum complications. Strike hard and strike early is the goal. How do we do it? We use the drugs. remember one thing, these are young patients at the beginning of their diabetes. They do not have vascular complications like atherosclerotic heart disease, they do not have heart failure, they do not have renal impairment, majority of them. So you can use the drugs which do not require a renoprotective effect, cardioprotective effect, as long as they are safe, but they should be strong and they should swiftly establish the control. And these drugs are modern sulfonylureas. Now, if you are talking, you require a drug which has a good glycemic efficacy, and I don't have to talk to you about the glycemic efficacy of sulfonylureas. It has been documented that they are having highest glycemic efficacy, and it has been recognized that they also act very quickly, and what is required for establishing a good glycemic legacy is a quick action and efficacious action. You don't use the older sulfonylureas or traditional sulfonylureas nowadays. When we use sulfonylureas, we use gliclazide or glimepiride, which are considered as modern sulfonylureas. They have lower risk of hypoglycemia, lower risk of higher cardiovascular safety, lower risk of renal impairment, and lesser chances of obesity. Among these two drugs, gliclazide, we have to accept it has an edge over glimepiride. Strong safety profile as regards hypoglycemia. I will show you what is the mechanism involved for that. Lesser weight gain, favorable CV safety studies documented in Advance and Stono, and there are a lot of epidemiological studies done to prove its efficacy also. Now, so we will restrict our discussion to those agents who establish control swiftly. Among the sulfonylureas, you have glimepiride and gliclazide, and GLIDE study is a well-known study in which the head-to-head comparison was gliclazide versus glimepiride. Both were efficacious in reducing HbA1c. Glimepiride reduced by 1%, gliclazide reduced by 1.2% at the age of 27 weeks. I have no time, but we have a lot of Indian studies, real life studies, retrospective studies to prove the efficacy of these molecules. And you also have international studies such as study by Kamlesh Kunti, where the efficacy and safety was proved. Now, after the efficacy, the next point is it should be safe. It should be safe in terms of hypoglycemia. Now here, the structural differences between gliclazide and glimepiride are responsible for even further lesser hypoglycemic chances. Gliclazide is azabocyclooctyl ring, is having azabocyclooctyl ring, whereas glimepiride has benzodiazepine structure. Now glimepiride attaches with the sulfonylurea receptors on beta cells at two sites, whereas gliclazide attaches with only one site. And that's why gliclazide's association is not as strong, not as reversible as glimepiride. And this minimizes the risk of hypoglycemia further, even though both of them are safe. And that is very much brought forward in a GUIDE study where 50% lesser chances of gliclazide as regards hypoglycemia in monotherapy and 70% lesser chances of hypoglycemia in combination with metformin. Another safety issue is the issue of minimal weight gain. A drug should not give rise to a weight gain, unlike the older sulfonylureas, pioglitazone or insulin. And here, a swift control of glucose toxicity, reduced chances of hypoglycemia, minimizing the patient's fear in his mind, which leads to defensive eating, are some of the mechanisms which lead to lesser weight gain with gliclazide as proved in these comparative aspects. VADT, ACCORD and ADVANCE were trials done to establish one question, whether a tight control in older patients will lead to a lesser complications. The only difference was in ADVANCE, the drugs was only gliclazide, whereas in ACCORD and VADT, those who took part in clinical trial were given choice to use their own individual drugs within the limits. And that's why it is a good study, comparative study to see what happened on weight front. And in ACCORD there was no weight gain. In ADVANCE there was no weight gain, but in VADT and ACCORD there was a weight gain. So why there is less weight gain, I have already told you. Now another issue is cardiovascular safety. We don't try to claim that the sulfonylureas, modern sulfonylurea have a protective effect on heart, but we have to prove that they are safe. In this term, again, a specific structural differences between glyclazide and other sulfonylureas leads to its relative safety, because these structural differences, because of that, glyclazide only acts on sulfonylurea receptors on beta cells, and that structure prevents their action on sulfonylurea receptors on cardiomyocyte as well as the smooth muscle cells in coronary arteries, which preserves the ischemic preconditioning reflex which is there when there is a repeated ischemia. And that's why this is one of the principles based on which cardiovascular considered to be a cardiovascular safe drug. Now I'll just show you a couple of studies. This is a Danish registry, and the findings are published in European Heart Journal. Gliclazide has lower CV risks as compared to other insulin secretagogues in patients without previous myocardial infarction, and in patients with myocardial infarction, the comparative drug was metformin. Gliclazide is only drug which came near metformin as regards the cardiovascular safety, whereas all other newer and older sulfonylureas were having a slightly higher risk, both with previous myocardial infarction and those without previous myocardial infarction. In other study, gliclazide was proved to have a lower all-cause mortality and also CV-related mortality. Here again, if you look at various other sulfonylureas, gliclazide was safer in a cardiovascular mortality as well as general mortality, and it was also safer as regards stroke prevention. Now, the last thing which you want your drug, besides efficacy, besides low hypoglycemia, low weight gain, cardiovascular protection, efficacy, quick action, and a renal protection, or at least safety from renal study. In this regard, gliclazide was studied in far more number of clinical trials, in far more number of patients as compared to any other sulfonylurea. It showed 21% reduction in nephropathy in advanced trial. It showed 46% reduction in development towards the development of end-stage renal disease in advanced on trial, which was a continuation study of advanced trial. And when directly head-to-head comparison in a long-term study which lasted for 66 months in those patients who started with normal renal function, gliclazide had lower risk of doubling creatinine versus as compared to glimepiride. This has been recognized by various nephrology associations like National Kidney Foundation and KDOQI when they have given the guidelines, and in these guidelines gliclazide was recommended to be used in the same dosage without dosage reduction up to stage 5 of renal impairment, whereas there was some restriction on glimepiride in stage 5, and in stage 3 and 4 it was advised to be used with caution. I am not saying that these modern sulfonylureas should be used left and right in every patient as the drug of first choice. When there are compelling conditions such as presence of atherosclerotic cardiovascular disease, heart failure, very severe obesity, renal impairment, you have to use SGLT2 inhibitor or GLP-1 analog as a first line drug with or without metformin. But here again, what will happen after some time as the diabetes progresses further with or without metformin, or with metformin, SGLT2, HbA1c control is not there. So there you can bring these drugs, modern sulfonylureas like gliclazide, as a third line drug. So in short, these are the indications. The indication number 2 is the commonest indication, but in those patients with a very mild diabetic where you are trying to control it with only one drug and metformin is contraindicated because of renal impairment or not tolerated, gliclazide comes there as the first line single agent. The most common use will be metformin plus modern sulfonylurea in a primary combination or add on to this drug when there is not sufficient control of HbA1c. Then there is a third condition in which the patient has atherosclerotic cardiovascular disease. You have used SGLT2 inhibitor along with metformin, but then you find HbA1c is not at the goal. You can bring in gliclazide at number 3 position there. So there are various different indications. You can add gliclazide to insulin to reduce the frequency and dosage of insulin, to reduce the weight gain to some extent. You can use gliclazide in elderly people because you know it is safe on hypoglycemia front, safe on cardiovascular protection front, and these are the various other indications such as in Ramadan, because gliclazide slow release is associated with far lesser hypoglycemia than you imagine. Don't take the general association of sulfonylurea and hypoglycemia as same with gliclazide. Now, in the recognition of its position, safety and efficacy, people are using it, and that's what is reflected in the JADE study. 1 minute please. JADE study was done in 11 Asian countries, mostly advanced East Asian countries and India, and they found out the physicians' practice, what physicians are doing, and in almost all the countries including India, sulfonylureas are most prescribed drug in India, and sulfonylurea metformin combination is the most common combination used. Now, last slide, the take-home message is, in short, India has lot of young type 2 diabetic patients without any cardiovascular disease, renal disease, where you have to establish good metabolic memory very quickly using the drugs which are potent, which are fast, and which are safe as regards cardiovascular system, renal system, prevention of hypoglycemia and prevention of weight gain. In such situation, modern sulfonylurea like gliclazide still has got a major role to play with. Thank you very much.